everyone. Thank you for joining us today for the Funding Announcement Opportunity webinar, linking the provider recommendations to adolescent HPV vaccine uptake. Before passing the presentation over to our speaker, Dr. Sarah Corbin, I would like to provide a few tips for using Webex that you get the most out of today's webinar. All attendees will be in listen mode only. Please feel free to submit your questions throughout the presentation in the Q&A panel and select all panelists from the drop-down. We will ask them on your behalf during the Q&A portion of the webinar. If you need to view live closed captioning, please refer to the Media Viewer panel. I wanted to note that today's webinar is being recorded and will be posted online at a later date. We also have a feedback survey. Please take a moment to complete that at the end of today's webinar. With that, I will pass the presentation over to our speaker.
Good afternoon, everyone. This is Sarah Corbin, and I thank you for your interest in this announcement and for making time today to hear more about it. Those of you who are more experienced with NIH grant funding, I hope will forgive me for doing a bit of an overview about the program that is sponsoring this research interest in HPV vaccine, and also about how NIH funding works for people who are less familiar with that. This is a helpful slide about the Webex and logistics that Jennifer just mentioned, but I think we can pass by. Ask Jennifer if you have questions. So just a moment about myself. I know many of you because I saw the list, but my name is Sarah Coburn. I'm the acting chief of the Health Systems and Interventions Research Branch here at NCI, and that's part of the Healthcare Delivery Research Program. And in our branch, we're very interested in the kind of multi-level understanding system context approaches to cancer prevention and control interventions, just as in this announcement. As an outline for the talk, I'll be giving you a little bit of background, more details about the FOA itself, and then I hope that the primary focus of today will be a chance for you to ask questions and to hear the answers. This is a very simplified schematic of our division's organizational structure. So NCI has several different divisions, and we are an extramural division working with investigators like yourselves around the country called the Division of Cancer Control and Population Sciences. And you can see there are several different programs within the division, and I work in the Healthcare Delivery Research Program. Within that program, we have 3 different branches. And the one that I sit in, you can see in the middle of this schematic, is Health Systems and Interventions. And I have colleagues who study outcomes, both patient-reported and other kinds of patient-relevant outcomes, as well as the Healthcare Assessment Branch, which holds the SEER Medicare database and studies other kinds of care delivery processes. This next few slides are information that is relevant to all of NIH-funded research, not specific to this announcement, but just a chance to give an overview for people to whom this is new information. It is still true that most of what NIH funds, and this is not just HDRP or even NCI, it's most of NIH funds what's called Investigator-Initiated Grants. And those of you who are familiar with what are called parent mechanisms, those came into being because once we went to all electronic, there was a box that had to be filled in with some kind of name of an announcement, but it's still true that most people use that parent announcement so that they can bring in their own ideas, not something that we have called for as a specific area of interest. However, we do also, as you know, publish announcements of different kinds, different funding opportunity announcements, we call them now, as a generic. And these are 3 of the major distinctions within that umbrella category. RFAs, which you may be familiar with, it stands for Request for Applications, and that is the only one of these 3 for which money is set aside. The 3 share the fact that they are authored by someone inside the institute who identifies an area of need in research and goes through a multi-level, no pun intended, an elaborate process of approvals within the institute in order to publish this as an area of interest. The distinction for the RFA is that along with the approval to publish the interest is a commitment to spending a certain amount of money on that, on the applications that come in. Those RFAs generally have only a single receipt date, sometimes a repeating one, but it can be a one-shot opportunity. And they are always reviewed by a separate scientific review group, so not one of the standing panels that most of NIH review, applications are reviewed by. So RFAs, and then two different types of PAs. You can see that both say program announcement, PA, and a PAR. Both of these are without money set aside, but do have the endorsement of the institute leadership as an area of science we wish to promote. And a regular program announcement usually has 3 receipt dates a year and is approved for a 3-year period. So once it comes open, it's open for all receipt dates for 3 years. And the difference between a PA and a PAR is the R, which can stand for several different things. Can be special receipt dates, so you might not use all of the ordinary receipt dates in a year. Could be a separate referral process, and it can be a separate review. And in this case, the announcement we're talking about is a PAR, which means that there's no money set aside for it, that the priority area is endorsed by the Institute, and there is a separate panel that comes together to review these announcements. Also relevant to the current announcement is that there are 3 different levels or mechanisms, we call them, of research projects that people submit applications for funding. The smallest one is the R03. The R03 and the R21 share a 2-year period, but the R21 has more money. And then the R01, or the research project grant, that's sort of the main type of grant that we fund. And they differ in scope, terms of years that can be funded, the amount of money that can be funded, and then several important other differences are that in order to do an R21, an R01, it's necessary that you have pilot data in place and a clearly circumscribed project that is well justified by existing data, as well as the investigator's own prior experience or team of investigators. The R21 is a 2-year period. You can see at the bottom it's only up to 2 years and is often for new exploratory developmental kinds of projects. And I'll be talking in just a moment about how each one of these types of mechanisms apply or plays out in relation to this HPV vaccine announcement. The smallest is the R03. It can also be 2 years. It's less money than an R21 and is generally not considered to be for something that's very experimental or very innovative. It is required to be different from what other people have done, but it doesn't have to be risky. Perhaps that's the right word. R21s are often considered risky. An R03 is a great mechanism for collecting the preliminary data that you might need in order to submit for doing an R01. People also develop measurements or conceptual models, that sort of small defined project with an R03. So now I will talk with you specifically about this particular funding opportunity. And I'm sure that you have signed on because you're interested in the topic and the promotion of the HPV vaccine. And I'm sure, therefore, you know that there is a lot of evidence that the provider's recommendation is a really essential component to a successful uptake, promoting successful uptake of the HPV vaccine. The purpose of this PAR is to place that provider recommendation into the healthcare delivery context and to understand how the delivery system either enhances or inhibits the effectiveness of that recommendation. It's not, strictly speaking, a study of the provider recommendation itself, but how that recommendation is in the context of delivery system, and so characteristics of the provider, him or herself, the parent or patient or both, and then the clinical setting are those kinds of contextual variables that we're interested in understanding, how they affect whether the provider makes the recommendation and whether that recommendation results in the uptake of the vaccine. And my view of this is that to do this kind of work, expertise really is needed in cancer prevention and control in both adult and childhood behavior, immunization promotion, and healthcare delivery. And because those areas of expertise are so diverse and not commonly found in the other kinds of behaviors that are promoted in care and reviewed routinely by NIH with their standing study sections, this announcement has its own separate review panel to bring together all the needed expertise to review the proposals. The three types of studies you can see on this slide now map approximately to the three different mechanisms I was describing a moment ago. So the first is to identify characteristics, provider characteristics, the parent or patient, again, practice level. So the same three levels being mentioned all the time across the announcement. But the focus here is that this is on identifying those characteristics. And that's the kind of project that might be done with a smaller RO3 mechanism, for example. The second type of study is to identify mechanisms, and unfortunately that's a different use of the word mechanisms. This is mechanisms in the causal sense by which these characteristics that have been identified operate to enhance or to inhibit uptake. And so a more sophisticated conceptual model might be the kind of risky effort that an R21 could fund, more money, the same 2-year period as the RO3. And the third type of study is developing and testing interventions to go ahead and actually increase vaccine uptake by targeting those characteristics that are identified at the levels. And I will say that you don't see the labels RO3 or R21 or RO1 appearing here, and that's because any one of them might be fit to a different mechanism in the grant sense. It's just a rough guideline for how they fit. The components of this announcement that are really focused on as essential to writing and perhaps reviewing applications and our interest in funding an application that is really responsive to this announcement is that they should have all of these characteristics, these key elements. So primary data need to be collected in the clinical setting where the vaccine is being both recommended and administered. So there is a context around which that recommendation can take place and actually come to the point of vaccine administration. Because we have very strong interest in improving the public health in the United States, and the primary recommendation now for the vaccine is for boys and girls, any proposal is expected to focus on both unless there is some compelling scientific or access reason, whatever. The reviewers will then decide what is compelling for excluding one of the groups. And similarly, because particularly at the time we were writing this, we wanted to focus on, it's a public health, even though this is a research announcement, we're very focused on how to use the announcement to promote public health directly within the United States. So we wanted to focus on closing the disparities in HPV vaccine. And as I'm sure you know, in the case of this particular behavior, the kinds of disparities that are familiar or expected for other kinds of healthcare delivery services have turned out to be different. So populations who might have lower access to other things have tended to have higher access to the HPV vaccine or higher willingness to have it, or both. So the point is not to define how this vaccine disparities compare to other behaviors, but to say that these applications must focus on populations where vaccine uptake is lower than the national average for girls for first dose. And then finally, and perhaps most integral to the whole announcement from a scientific perspective, is that it's necessary to consider and measure characteristics of all three of the levels. That is to say, again, the provider as one level, the patient or parent as a combined other level, and then the practice or setting characteristics. Some details on this slide, some of them information specific to these announcements, and some really good practice for any time you're applying for NIH funding is, of course, to read the announcement very carefully. And although the meat of it is in one section, Section 2 and Section 4 are the places where the most details that are unique to an application are included, it's still true that every single detail is relevant. Any of them are boilerplate and relevant to all NIH grant applications, but still have to be looked through carefully. These announcements, the first submissions were September of last year, almost exactly a year ago. As I said before, the standard submission dates apply, so all three of the regular dates and the 3 years that it's open for. If you just look up NIH submission dates, this PAR follows the regular dates. There is no letter of intent that's due. If you're interested in how soon can I start my research after the time I submit my application, you can find the standard dates, start dates for NIH on the website as well. I don't know. Do we have a link to that? Could we add a link to NIH standard dates? I'm not sure if we have it on here somewhere. And then currently the announcement is scheduled to expire in July of 2019, and whether that is an actual end or whether, starting a year from now, I'm working on having it renewed. It depends on how many people are applying and how much good work is being done. And of course, as with any NIH application, start early. Allow yourself plenty of time for getting into the system, for mistakes that come through the system, and for your final application to be approved and received before the end date. This is information to contact me. I am the point of contact for this, and I know many of you have, in fact, contacted me, so I'm very happy for that, and please do it again anytime. We are going to be posting the webinar and the FAQs. Jennifer mentioned it'll be recorded, so you can hear the questions that I hope are to come and the answers, and then we will take that group of questions and answers and put them on the website so that people don't have to listen to the whole thing to get the questions and answers. Here is a promotion for our social media presence. Please stay connected with us. And I am looking forward to hearing your questions. Did I miss anything? You did this? This is where we want to be, right? Yeah. I leave this up or questions? Questions. Questions, okay. So I'm going to start, let's see. Okay, so the first question that's come in, I'm going to read it first and then answer it. If you are proposing to develop and assess the effectiveness of an intervention that's aimed at 2 levels, the provider and the practice setting, is that acceptable for this FOA? So the answer is that for both the R21 and the R01, it is necessary to conceptualize and measure at all 3 levels. It is not necessary to intervene at all 3 levels. So if you're interested in intervening at 2 levels, what you need to do is have both baseline and outcome measures that reflect your understanding of how the different levels influence each other. That could be interaction, it could be mediation, it could be, there are lots of different analytic ways to be thinking about that, but you should be conceptualizing how, for example, let's say the question was about the provider and the practice. So if you are intervening with the provider and changing what the provider is saying, how is that going to affect the routines of the nurses who work around the provider and expect to come in to give the shots after 5 minutes? Are you changing something that has an impact on what happens at the practice level as well? So not okay to do one from column A, one from column B, one from column C, but necessary to be hypothesizing and measuring how the different levels affect each other. Another question is whether older teens and young adults can be included, and the answer is that they can be included, but the primary focus still needs to be on the 11 and 12-year-olds. So if it makes sense within a clinical setting where you're working to be vaccinating everyone who's eligible, that's fine, as long as you have the power and focus on the 11 and 12-year-olds. Yes, someone did ask about the special review panel, and I could just return to what that means for a moment, which is rather than one of the standing study sections that exists at CSR, the Center for Scientific Review, a separate panel managed by CSR is put together for every one of these reviews, bringing together expertise that's necessary for understanding changing kids' and adults' behavior in the healthcare setting and measuring healthcare delivery types of outcomes as well as individual level. So there is a separate panel that reviews these every time. And I have the opportunity to talk with that panel and to do, I don't know, at least a conversation sort of like this one so that they understand the intention before they start reviewing the applications. Another question is whether secondary data can be used. In the text of the announcement, it does say, as I mentioned to you early on, that it's necessary to collect primary data in a clinical setting. It's possible to use secondary data for the purposes of identifying a population who have lower uptake. It's not necessary that you need to do primary data collection to identify that group, but the main focus of the research has to include the primary data collection. Okay, another question is about the other end of the age group. Is it okay to include 9 and 10-year-olds? And yeah, the answer is the same, because the recommendation for the vaccine, of course, begins as early as 9, and I know that there are clinical settings in the U.S. where they're already beginning to make vaccine recommendations at 9 as routine practice. That's fine, but the answer is still the same. The main focus needs to be 11 and 12, because that is what the national recommendation is. Another question is whether the delivery setting has to be able to document low uptake. And the simple answer is yes, but the more complicated answer is that there are a lot of different ways of getting at that. There might be, as I said, secondary data that somehow are available to show that. It might be an extrapolation from state or county level data. So there needs to be some good faith effort put towards identifying that this particular population has lower uptake, and then of course it will be the reviewers who decide whether that argument has been made convincingly. Okay, somebody sent in a lot of questions. Let me see. Funding for PA, how does funding work for PARs is one part of the question. And so, as I said, most of what NIH funds is still what we call investigator-initiated. And so PARs, even though they are in response to a call for hours for our particular scientific area of interest, are funded through the same research project pool of money that NIH has to spend on research funding every year. So there isn't money set aside, but there is an enormous fund of what NIH funds that these come out of. Okay, I'm going to have to disentangle what some of this means, but one of the question is, what does early investigator and first-time R01 do for you in the scoring process? So a first-time investigator or new investigator is what we say is somebody who has not successfully competed for an R01 level award in the past. So, and both of those are very important. So successfully means you can submit and not be funded 10 times, which of course we don't want, but if that happens, you do not lose your new investigator status. It's not until you have successfully competed that you are no longer a new investigator. So you receive your first R01 and then you're not. And the competed part is also important. Sometimes the principal investigator for a project leaves and another person is given the role of PI for that project. That person, if he or she has never before successfully competed, is still a new investigator. So you might be in the role of PI for an R01 that somebody else competed for, and it doesn't change your new investigator status when you apply for one yourself. A question about whether you have to request a special review panel. No, you don't. You need to just identify that you're submitting in response to this PAR, and you will be assigned. Definitely a word to the wise when you have, once you've submitted it and you see where it's been assigned, it's worth your double checking that CSR didn't make a mistake and send it to a different review panel. We do that before every review, check all the way through all submissions to make sure nothing went awry, but it would be helpful for you to be part of that quality chain. The special review panel doesn't have a separate name. Someone asked about that. I'm sure it's like ZRG 123 something something, but you don't need to know that, and then because you don't need to request it, it doesn't matter. It is just the special emphasis panel put together for this PAR. When you look at ERA Commons or where you see where you've been assigned, it should say the name of this PAR as where you've been assigned for review. Someone asked if it's necessary to address series completion of the vaccine series, and no, the answer to that is no. If you have the time, if that's the kind of intervention that you're prepared to do, by all means, but no, the focus of the announcement allows you to decide that, and it's only first dose that you'll need to have. Someone asked, how broadly is primary care provider defined? And I think what I said earlier in the slide was that you need to be in a context where someone can make the recommendation and that person or other people can deliver the vaccine. So presumably that's mostly pediatricians, family docs. I think I'm less interested in defining primary care provider than I am in providers who can both make the recommendation and within the same context of the same visit be delivering the vaccine. Is there a preference in this PAR for proposals that include 2 or more delivery systems over proposals that include only 1? I think no. The short answer is no, and the long answer is I think it would be very hard within even a regular R01 budget to be looking at 2 different delivery systems and hypothesizing about differences between them. If you can, by all means, there's no prejudice against, but that is not the expectation. There's a question that I'm not completely sure of the meaning of. It's about percentiling. The question asks, the percentiles for each mechanism, do they compete with other NCI-submitted grants for different PARs and investigator-initiated calls? So short answer is yes, because as I said, there's one very, very large budget at NIH for all of the non-RFA funding opportunities, so yes is the answer because money is not a set aside. One thing to note is that R03s are not percentiled. They are, in fact, none of these proposals are percentiled. That's the more important point. Because they are being reviewed with this standing study section, they get compared to, I may have just said the wrong thing, hold on. They are, in fact, percentiled, and they're percentiled in comparison to CSR all, which means everything that gets reviewed through all of the standing study sections in CSR, the scores of the proposals that are reviewed by this under this PAR get compared to that whole list in order to have percentiles developed. But R03s don't get percentile anyway. So there's a question about the appropriateness of an investigator who has clinical expertise with HPV-related cancers and quality improvement, but no published manuscripts on the vaccine. Would it be better to submit an R21 and R03? So first of all, it's good to see that you understand that if you don't have preliminary data, that you wouldn't be thinking of an R01. In choosing between an R03 and an R21, I think you're much better guided not by your own experience, but by the nature of the research that you want to do. So is it a small project like developing a new set of measures for a particular population or collecting preliminary data that you think would be valuable in developing an intervention later? Those might be more appropriate for the R03. And then the R21 is if you have something a bit riskier, and the example that I gave was beginning to understand the mechanisms by which the different characteristics of the setting might influence each other. That requires collection of more data, that's more risky in the sense that it's possible that nothing positive will be learned. Again, it's about the research you want to do, what it costs. So the big difference between the R03 and the R21 is the maximum amount of the budget. If you want to work in a state, someone asked about working in a state where vaccine uptake is high, but the interest is in identifying a vulnerable population or a population with low vaccine uptake. There's nothing about this announcement that makes it specific to a state. I know that the National Immunization Survey teen data are reported by state, but there are many other sources of local information about vaccine uptake, and so there's no necessity to choose a state to work in where vaccine uptake is low across the state. Yes, there is a necessity to identify a population, whether vulnerable in other ways or not, a population where vaccine uptake is low. A question about whether applicants who have not had prior NIH funding before are encouraged to apply, and yes, certainly the answer to that is certainly yes. I mean, there are, as I mentioned, different kinds of questions that could be answered. People who have more or less preliminary data or more or less experience working in an area are certainly enthusiastically encouraged to apply and to call and talk to me about what's the best fit for the research ideas that you have or your scientific questions, what resources are available to you and your own expertise and team. Okay. I'm not seeing any more questions. So given that, I'm just going to thank everyone very much again for taking the time today. Remind you that the questions and answers will be typed up in a more formal and practiced way, and we will be putting FAQs on our website. You're welcome to contact me, as you saw my contact information a few different times, to talk about this. And I hope that you will apply. It's an important problem, and I thank you again for your time. And that's the end of today's webinar. Bye-bye.